Myself, Dr. Sojit Tomo. I am Assistant Professor in Department of Biochemistry. And today I'll be talking about therapeutic drug monitoring, a laboratory perspective, our experience from past 1 year. So therapeutic drug monitoring involves the assessment of drug concentrations in patients' blood to optimize the drug dosage. It's a multidisciplinary process which involves different stakeholders such as the ordering physician, clinical laboratorian, the clinical pharmacologist, and the nursing staff. The TDM, therapeutic drug monitoring, enables us for the practice of individualized drug dosing, and this helps to enhance the drug efficacy and reduce the risk of toxicity. But the TDM practice is reserved for drugs which have well-established relationship between the blood concentration and the clinical effect, and it is targeted for drugs which are having unpredictable pharmacokinetics and those drugs which have narrow therapeutic index. So just to introduce the terminology before going into the discussion, we have three terms. We have pharmacokinetics, pharmacodynamics, and pharmacogenomics. Pharmacokinetics is what the body does to the drug. Pharmacodynamics is what the drug does to the body, and how the genes affect drug metabolism and clinical effect. That would be the pharmacogenomics. And pharmacokinetics is assessed by the drug levels, and pharmacodynamics can be assessed by the evaluation of clinical response and biomarkers. So the pharmacokinetics affects the amount of drug that is there in the blood, and what we are concerned about in the laboratory is to assess the drug levels in blood sample. And this is affected by various factors that affect the pharmacokinetics of a drug, and that includes liberation, absorption, distribution, metabolism, and elimination. So while discussing the concentration of drug levels in blood, we need to understand the therapeutic range before going into the assay. So to understand the therapeutic range, we have two terms. One is the minimum toxic concentration, and the second is minimum effective concentration. So the blood concentrations greater than the minimum toxic concentration put patients at risk for toxicity, and the concentrations less than minimum effective concentration put them at therapeutic failure. And the smaller the difference between these two, smaller the therapeutic index, and more likely the TDM will be necessary. So a robust TDM program, it helps in better management of patients and has the potential to improve patient quality of life through optimizing dose, supporting compliance, and minimizing toxicity. But to be effective, the program requires acquisition of a valid specimen, followed by timely determination of the drug concentration in the specimen and interpretation of the results in the context of dose, time of last dose, and other concurrent drugs present. So coming to the role of laboratory in testing therapeutic drug monitoring processes. So we have two factors. Either we can go for detection of risk factors, or we can look for quantification of drug or its metabolite concentration. So while we're looking for risk factors, it would be the pharmacogenomics. And when we look for the drug levels or its metabolites, we are looking at pharmacokinetics and the biomarkers which are indicative of clinical responses. But there are different analytical challenges before we can take a drug into therapeutic drug monitoring. So that includes the need for accurate and reproducible methods, the requirement of quality assurance and proficiency testing programs, the necessity of establishing target ranges and critical values, and the pre-analytical issues which are specific to individual drug assays. There are different methods for estimating drug levels in blood, but what we are currently practicing in our lab involves two methods. One is competitive immunoassay using direct chemiluminescent technology, and the second is enzyme multiplied immunoassay technique. So these are the two techniques that we are employing in our laboratory to estimate the drug levels. So we started the journey of TDM with the anti-epileptic drugs, which includes phenytoin, valproate, and carbamazepine. And subsequently, we have started with methotrexate estimation in the patient samples. The two platforms that we are currently using for TDM are the Siemens Automatic Advia Centaur Immunoassay System and the Beckman-Coulter Clinical Chemistry System. Now on Siemens, we are estimating phenytoin, valproate, and carbamazepine, all the anti-epileptics. And on Beckman-Coulter, we are estimating the methotrexate. Coming to the methodology, for all the anti-epileptics, we are following competitive immunoassay using direct chemiluminescent technology. And for the methotrexate, we are going for enzyme multiplied immunoassay. And the sample specimen that can be used is serum and plasma. And currently in our lab, we are accepting serum samples for the TDM. So to describe the process of launching a TDM for a drug, it starts with the identification of clinical need or the demand from our clinical colleagues. So once we realize that there is a requirement for a TDM for a drug, we then move on to identify the method. And if we have the right method, we move to see whether we have the right platform and the technology. So if we have the right platform and technology for estimating a drug, then we will see whether there is an appropriate quality control program and an external proficiency, external quality assurance system that is available for the drug that is to be assayed. And if both of them are available, then we move on to procurement of reagents and control. And when we get the reagent, we will program it in the instrument, and then we will move into calibrating the instrument. And once the calibration passes successfully, we will run the internal quality control. And if the internal quality control passes successfully, then we will enroll ourselves in an external quality assurance program, and then we will initiate the test for the patient care. So this is the process that we follow for launching a TDM into clinical care. So to go into our experiences, in last 1 year, we have 331 samples for the TDM analysis, out of which a major proportion was valproate, around 55%, followed by phenytoin with 27%. The number of samples that we have received for valproate was 182, and the number of samples that we have received for phenytoin was 91, followed by carbamazepine and methotrexate. So to discuss the anti-epileptic drugs, we are performing the anti-epileptic drugs on Siemens platform using Siemens kit for all the 3 drugs, phenytoin, valproate, and carbamazepine. And it's a competitive immunoassay with direct chemiluminescent technology. The principle is anti-epileptic drug in the patient sample. It competes with the acridinium ester labeled anti-epileptic drug in the reagent. So to practice the TDM, we follow the anti-epileptic best practice guidelines for TDM by the Patsalos in 2008, which has been updated in 2018. So they have given the definition for the reference range and therapeutic range, which is slightly bit different from the normal clinical chemistry parameters. So as in TDM, the reference range is defined as a range of drug concentration that specifies a lower limit below which a therapeutic response is relatively unlikely to occur, and an upper limit above which the toxicity is relatively likely to occur. And this is a population reference range. And the therapeutic range is defined as a range of drug concentration which is associated with the best achievable response in a given person. So this is an individual-based therapeutic response. So the therapeutic range would be determined for an individual since the range differs between the individuals. So what the guideline states is to devise an individual therapeutic concentration for each drug and a population-wise reference range for each drug. Now, why do we have to do TDM for the anti-epileptic drugs? So there are different rationales behind it. To name a few, the TDM can be done when there is a dose adjustment aiming at a pre-selected target concentration. And if we want to establish an individual therapeutic range, if there is signs or symptoms that are suggestive of concentration-related anti-epileptic drug toxicity, and if there are drugs which are having altered pharmacokinetics, and if we want to assess the change in steady-state anti-epileptic drug concentrations, and if there is a suspicion of poor compliance. So before launching the drug for clinical care, we have 3 processes which assures us the quality of the assay. So we have calibration, internal quality control, and external quality assurance. So in calibration, we will be going for traceability. Using traceable calibrators will help us to harmonize the assay between different methods and different instruments. In internal quality control, we will be looking for the precision of the assays. And in external quality assurance program, we would be able to assure the accuracy of the assay. So for anti-epileptic drugs, for the calibration, we have calibrators which are traceable to the standard reference material from NIST. In phenytoin, it is SRM 900, and for valproate and carbamazepine, it is SRM 1599. For the internal quality control, we are using LifoCheck immunoassay plus controls from the Biorad, and we have also enrolled in an external quality assurance, which is the Biorad's IQUAS Therapeutic Drug Monitoring program. So the calibration, after calibration is successfully passed, we will be performing an internal quality control, which would have 3 levels of control. And once we have the 3 levels of control passed for the anti-epileptic drug, we will be also looking into the external quality assurance program, which shows consistently normal results. Going into the individual drugs, we have 3 anti-epileptics that we are performing in our lab: carbamazepine, phenytoin, and valproic acid. The reference ranges for the carbamazepine is between 4 to 12 milligram per liter. For phenytoin, it is between 10 to 20 milligram per liter. And for valproic acid, it is between 50 to 100 milligram per liter. And this is the population reference range. The observed half-life is for carbamazepine between 8 to 20 hours. For phenytoin, it's large, between 30 to 100 hours. And for valproic acid, it is between 11 to 20. Both phenytoin and valproic acid have excessive protein binding when compared with the carbamazepine. And there are different enzymes which are metabolizing these drugs, especially for valproic acid. There are a lot of enzymes that plays crucial role in eliminating the drug, which brings in more variability to the drug. One thing that I would like to invite the attention is the time to steady state, which is for carbamazepine is between 2 to 4 days. And for phenytoin, it is between 5 to 17 days, and valproic acid, it's between 2 to 4 days. And this time to steady state of a drug, it is dependent on the T-half, the half-life of the drug. So approximately the time to steady state is between 4 to 5 T-half after the dose has been started. And this time to steady state ensures that the drug has reached a steady state concentration in the patient while we are estimating that patient sample for that drug. While assessing the distribution of these drugs with respect to the reference ranges, we have seen that there is substantial number of samples which are having drug levels which are below the reference range, outside the reference range. And for phenytoin and carbamazepine, there is substantial number of samples which are below the reference ranges. So this observation is concurrent with studies from Chennai by Hari Venkatesh. They have also explored the same technology and the same reference range. And they have also seen that there are substantial number of samples which are outside the population reference range in case of anti-epileptics. And this can be due to multiple reasons. This is because of the drug's characteristic with respect to its metabolism. So for carbamazepine, we have a 75% protein-bound drug which have different half-life at different phases of its treatment. So in case of initial doses for the carbamazepine, we have a half-life of 18 to 55 hours for the adults. But as we move on to the maintenance dosing schedules, the half-life of carbamazepine decreases to 8 to 20 hours. And this is due to an auto-induction of the carbamazepine. The enzyme that is metabolizing carbamazepine, which is CYP3A4. And when this auto-induction happens, the half-life changes. So when we take the sample from a patient, we should also need to know whether the schedule is at an initial dose schedule or at a maintenance dosing schedule. There are other factors which are also involved with respect to the enzymes that is metabolizing the carbamazepine. So there are drugs such as erythromycin and phenytoin which induce the enzyme and it reduces the concentration of the drug. And there are drugs such as itraconazole and the grapefruit juice, which again inhibit the enzyme and it increases the concentration of drug. So assessing the drug levels should be done with respect to the concurrent drug administration as well as the dietary factors. Coming to phenytoin, phenytoin is 90% albumin bound. And similar to carbamazepine, here also there are different drugs which are activating the enzyme, such as alcohol, carbamazepine, barbiturates, which will again reduce the total concentration of drug in the blood. And there are drugs such as chloramphenicol, cimetidine, disulfiram, isoniazid, which again increase the amount of drug that is there in the blood. And because this phenytoin is excessively protein bound, those drugs which can displace the phenytoin from the drug binding, the protein binding state, it will also lead to an apparent decrease in the total drug level, but here the free drug level would be normal or increased. One another interesting characteristic of phenytoin is the hepatic metabolism of phenytoin, which becomes saturated within the therapeutic range. So What happens here is, in the therapeutic range itself, if a saturation occurs with respect to the hepatic metabolism, there is a non-linear relationship between the dose and the blood levels. So this makes a strong case for the therapeutic drug monitoring of phenytoin in patients who are having saturated hepatic metabolism. Similar to phenytoin, valproic acid also has 90% protein bound fraction, but the extent of protein binding, it decreases with increasing concentration, again leading to a non-linear kinetics in some patients. And here we have multiple enzymes which metabolizes valproic acid via oxidation and glucuronidation, and there is large inter-individual differences in the rate of drug metabolism. And this brings in a poor correlation between the valproic acid dose and the serum concentration, and this again builds a very strong case for TDM in valproic acid in case of patients. That was anti-epileptic drug. Then we introduced the methotrexate in the latter part of last year. We are using the Siemens Syva kit for methotrexate, and it is based on a competition between the drug in the sample and drug labeled with enzyme glucose 6-phosphate dehydrogenase for the antibody binding sites. Now, what is the rationale for establishing a TDM for methotrexate? So the methotrexate is estimated at 24, 48, and 72 hours after a single dose to identify methotrexate toxicity. And if there is a methotrexate toxicity, we have to administer leucovorin, which is an folic acid analog, to rescue the cells from the methotrexate toxicity. And in addition, if we have a period of high serum concentrations of methotrexate, then we also have to maintain a large volume of alkaline urine so that there is no precipitation of methotrexate in the tubules, because the pKa of methotrexate is around 5.5. So we have to monitor the serum concentrations. So there is a case for TDM for methotrexate because it's related to the timing of initiation and continuance of leucovorin treatment and the management of urinary pH. So to understand methotrexate toxicity, the toxicity is defined as at 24 hours, at 48 hours, and at 72 hours. If it is at 24 hours, more than 10 micromole per liter, then the patient is more prone for toxicity. At 48 hours, the cutoff is around 1 micromole per liter, and at 72 hours, it's 0.1 micromole per liter. The half-life changes with the duration, and there is not much enzymes that is active in methotrexate metabolism, but it's the renal elimination that is there for the methotrexate. So similar to anti-epileptic drugs, we need to do the calibration, the quality control, and the external quality assurance for assuring the quality of the assay. So we have a 5-point calibrator here that we use to go for the calibration, and similar to the anti-epileptic drug, we have a Biorad LiFoCheck therapeutic drug monitoring control for the internal quality control, and we have also enrolled in the IQVIA's therapeutic drug monitoring program of Biorad for the external quality assurance. So once we have a successful calibration and internal quality control which is passed, then we will be enrolling in the IQVIA's therapeutic drug monitoring program for the external quality assurance, which also shows optimum results. We have received around 33 samples of methotrexate in the last 2-3 months from 11 patients, out of which 10 patients were having ALL as a diagnosis, 1 patient had primary CNS lymphoma, and 1 patient was having diagnosis of rheumatoid arthritis. So there are some inherent limitations in our assay, which is known. So there is significant cross-reaction for aminopterin, which is an anti-neoplastic agent, but not usually administered concurrently with the methotrexate. And another metabolite, a minor metabolite of methotrexate, which can also act as a cross-interference in our assay. But there are drugs which do not have any interferences. So the other drugs such as cyclophosphamide, doxorubicin, 5-fluorouracil, vinblastine, and vincristine have been proven to have no significant cross-reaction and interference in our assay. So the best practice for the methotrexate, it depends upon the infusion schedule. So we have a 24-hour infusion schedule, and we have a rapid infusion schedule, which is between less than 6 hours. So for a 24-hour infusion schedule, the sample should be taken at 24-hour or at the end of infusion, and followed by a sample at 48-hour and at 72 hours. So the first sample would help us to assess the steady state concentration of the drug, And the second sample would help us to understand the toxicity of the drug. And for a rapid infusion schedule, we should take a sample at the end of infusion. Can be anywhere between 3 to 6 hours. Then samples at 24, 48, and 72 hours. Now, there are different challenges we have while establishing a TDM for any drug. So one of the major challenge is the dilemma between the total fraction and the free fraction. So because almost all the drugs are protein bound to an extent, there are conditions where this protein binding of drugs can vary, and that lead to the imbalance between the total and the free fraction. So some of the examples are patients with renal failure, patients with liver disease, patients who are having hypoalbuminemia, or in patients where drug concentration do not correlate with the clinical expectation. In all these cases, the consensus is to go for free fraction of a drug. But currently, we are not able to do on our platform free fractions. We are able to do only total fractions. And there are formulas which has come, Winter-Tonser equation for phenytoin, which will help us to calculate the corrected drug levels in case of hypoalbuminemia. But still, consensus is not there when to use. It is not validated for different clinical scenarios. The work is going on in this field. So this is a challenge that we have, when to go for free fraction and can we depend on the corrected fractions. Another challenge that we have is because of different methods. We have different methods for estimation of drug, and because of different method, there is a comparison between the methods. And because of the inherent change in the principles of estimations, there are differences between these. But as we move on to have traceable calibrators, we can able to minimize these differences, but still there would be differences between the methods with respect to the precisions. Another challenge we have is the variation in dose. So an example is Methotrexate, which have two extreme dosages. The high dose Methotrexate in case of CNS lymphoma and low dose Methotrexate in case of rheumatoid arthritis. So this calls for a Methotrexate TDM separately for autoimmune diseases apart from the high dose Methotrexate. So the chronic toxicity data of the low dose Methotrexate TDM, it can be tuned in for understanding the Methotrexate non-responder profile in patients with rheumatic diseases. And one of the significant challenge we have in case of TDM in the laboratory is the timing of specimen collection. So the specimens are drawn at either the peak or at pre-dose, that is the trough, or it can be collected randomly, but it depends upon the clinical indication and the characteristics of the drug. So in case of a patient presenting with toxicity, we will be going for peak collection, as in case of aminoglycosides. In case of a steady state concentration, if it is need to be assessed, then we should be looking at the trough concentration, as in case of anti-epileptics. For those drugs which have very long distribution phase, for those drugs we can go for random collection, as in case of digoxin. So to conclude, some of the take-home points from our experience is these pre-analytical precautions. For Methotrexate, it have to be stored at around 2 to 8 degrees Celsius, and it has to be protected from light because the Methotrexate in solution is light sensitive. And for transporting, the sample temperature should be maintained between 2 to 8 degrees Celsius. And we need to ensure that the timing of sample collection is dependent on the clinical need. If we are looking for a steady state concentration, then the sample should be taken 4 to 5 half-life after starting the treatment, preferably before the next dose, just before the next dose. But if you are looking for a drug toxicity, then we should take the sample at the time of presentation. And if we are looking for an establishing individual therapeutic concentration, the guideline states to have 2 separate determinations which have to be obtained at intervals of months or years when the patient is symptoms free. So based on our experience, we have tried to change the TDM requisition form for including more information. So this was our old TDM requisition form. So in the new TDM requisition form, we have included the indication for TDM. So it would make the users aware what is the purpose of using the TDM, whether it is for the steady state concentration or for drug toxicity or for individual therapeutic concentration. We have also included the drug dose and schedule, which again influence the drug assay. And we have also added the symptoms and signs of drug toxicity and any other drugs that is being administered concurrently to the patient. And if the patient is having any comorbidity with respect to liver, kidney, or if he is a patient of chronic alcoholism, because all these factors affect the drug metabolism and the amount of drug that is there in the blood. And if there is presence of breakthrough seizures in case of anti-epileptics. So we are going to upload this form in the Quick Docs. Anyone can download this from the Quick Docs. And these relevant information, the judicious entry of this information, the TDM requisition form, it would help us to have more meaningful discussion with all the TDM stakeholders and can give more meaningful results. So coming to the cost, phenytoin, the cost to the patient for phenytoin is 600 rupees, for valproate and carbamazepine it is 400 rupees, and for methotrexate it is 1040. And in future we are going to launch tacrolimus as the next drug candidate for TDM. And apart from this, we have on our platform that is available with us, we have the ability to perform all these drugs, but it depends upon the clinical need and the clinical demand. To discuss the biochemistry department's research in brief, the thematic areas that we are focusing are infectious diseases, cancer, heavy metals and trace elements, molecular psychiatry, non-communicable diseases, and biomarkers. So much of our work is done in infectious diseases with respect to tuberculosis and drug-induced liver injury. In cancer, a lot of work is being done in epigenetics, immunomodulation, genotoxicity, and elucidation of different pathways, liquid biopsy in colon cancer, the metabolomics in cancer, and cholesterol homeostasis. In heavy metals, we are actively exploring genotoxicity and epigenetics. In case of non-communicable diseases, we are looking into the immunophenotyping, the effect of phytochemicals, and the metabolomics in diabetes. Apart from this, we are also actively exploring biomarkers, especially in sepsis, and their validation in clinical laboratory. And we are also working in toxicology, thanatochemistry, epigenetic alteration of reproductive medicine, and clinical epigenomics. So on behalf of Department of Biochemistry, I welcome all the departments to have very exciting collaborations with us. Thank you.
Thank you. Very nice talk. As you mentioned that you are going to start, Professor Mithu also knows that we are going to start tacrolimus levels. So what about the levels of cyclosporin and everolimus? Because this is also required in transplantation process like C0 level and E0 level. Are we going to start that also? Any comments?
Dr. Vaibhav, as we've discussed earlier, by beginning of next week, we should be able to give you tacrolimus. And I'll have to explore whether with the present platforms, we will be able to do everolimus and cyclosporin. I will need to check back. Right now, the focus is on getting tacrolimus standardized and giving meaningful results to you.
Thank you for making us aware. My question is related to valproate. So here, as it is 50 to 100 is the therapeutic range, but in some guidelines it is up to 125. And the second, in the same related to valproate, they are different preparation. If it is extended release once a day preparation, then trough level 24 hours. So it is not hard in the paper, so still many clinicians send after 12 hours. And the third, the last is any plan for lithium, availability of our machines, because we have this. Thank you.
For valproate, we have, with respect to the bipolar disorder, yes, ma'am.
You get to the slide on where you have the reference range for valproate, if you can, please. Yeah, that level.
This reference range for valproic acid is a population reference range, and it is dependent upon the presence of toxicity. But again, we need to titrate this reference range with respect to different diseases also. So I think in 2022 December, there is one article that has come in eClinical Medicine with respect to the role of the levels of valproate in bipolar diseases. And there it was between 50 to 74. So again, we need further studies to look into the levels of drug and its correlation with the clinical implications. And with respect to the formulations, the different formulations can lead to different drug levels, but I think clinical pharmacology can have better opinion in this.
So, Dr. Nebinani, what these reference ranges are actually population reference ranges. So that's why it is advocated that for every individual, once the patient is stabilized, determine your personalized therapeutic reference range. Once the patient is stabilized. Say for anti-epileptics, once he's seizure-free, get his sample once, then call him after 4 weeks, do the second level, and then determine your therapeutic. So also for this, these are just population references. For every patient, it is advisable to get his or own individualized therapeutic reference range. Pertaining to lithium, it is in mind, but how many patients will we get? I don't think you use it very commonly, do you? And secondly, we have another alternative on our IAC, ion selective electrode. If need requires, we can put a specialized lithium electrode and give you results. But that will be a function of how many samples we'll be getting. We'll be able to give you timely reports. That should not be an issue, but we need to sit and determine the numbers, sample numbers.
Very nice presentation, Dr. Sojit and Biochemistry Department.
Thank you, sir.
We are now having more technology development at Biochemistry. Now we have sequencer also, and in the microbiology we have NGS also. So any plan for doing like genotyping and finding out the correlation with the TDM? Any plan for development of pharmacogenomics?
Sir, pharmacogenomics would be basically doing an SNP genotyping, which we can do on a real-time chemistry platform. We can go on with Sanger also. It is very doable. So we haven't planned anything. At this point in time, there is one project going on, extramural, in which we are doing INH levels. And my collaborators in Manipal, they are deriving population pharmacokinetic reference ranges so that they can implement at a population reference level at what dose you should start INH. So that is one thing, and we can start any of the, while I was talking to the neurologist, they say that carbamazepine has Steven Johnson's. That is a risk. So maybe we can do that SNP genotyping and tell them that, okay, this patient may or may not get SGS, which can turn fatal. So.
Okay, thank you. Another thing is that now we are moving toward the precision medicine, personalized medicine. And one thing is that by using all these labels, we can correlate the severity or the side effect of the drugs. But at the same time, I think there's a more emphasis should be on the clinical precision medicine, that is phenotype. What phenotype? That means there is a more detailed history is required from the patient. And in homeopathy, there is a term like repertoire. They map the whole of the patient's phenotype. I think similar, if they can be adopted and they can be correlated with TDM, we can have a more data about how we can use it more effectively.
Yes, sir.
There are two things that I would like to highlight here. Number one, that pre-analytics make a lot of difference. If you don't get a good sample, we'll not able to give you a good report. So two things have to be kept in mind. One, we always say that send a serum sample, and please remember that this serum sample has to be sent in a red vacutainer which does not have a gel, because the gel sometimes absorbs the drug molecules and it might then give a subtherapeutic concentration. So that we have to keep in mind, that we have to send the samples in a red vacutainer. Second, if drug has been given on a particular IV line, from that same line we should not draw blood, because it is known that some of the drugs adhere to the IV line. And when we draw blood from that line, some of these molecules will get flushed out with the blood, and that might falsely give a high result. So these two things have to be kept in mind. Number one, red vacutainer. Do not draw blood from the line in which you have infused the drug. These two could be big. One would be false negative, and the second one would be a falsely positive high result. And then you will be trying to interpret, and it will not be easy to come out with an outcome. And secondly, this form that we have designed, we thought we were not getting enough inputs and that was becoming a challenge for us. So therefore, it's from our side, we would require all of you to cooperate, and if you look at here, the tick boxes are very, very clear. So that helps you also when you're asking for a drug level to know what is the clinical question that you have in mind. And when we report out, we know whether your question has been adequately addressed. So it'll take just 2 minutes for you if you fill these tick boxes. One being steady state, whether it is for steady state. Second, whether it's toxicity. For toxicity, as discussed, please send peak samples. Steady state after 4 to 5 half-lives of starting the dose. Third is individual therapeutic concentration after the patient has been stabilized at 2 intervals. And the last one, non-compliance. And as all of you agreed, almost 50 to 60% people are non-compliant, especially those who are on long-term anti-epileptics. So that'll help us in also knowing whether your question has been answered by us with that one value that we are giving. And then, of course, comorbidities as discussed, liver disease, kidney disease, chronic alcoholism. That is important because we are doing total levels, we are not doing free levels. So when you are interpreting, this becomes very important, whether there are any comorbidities present. So that's all from our side. Sojit, that was a very, very lucid and good presentation. And we require this cooperation from your side so we make this TDM program more meaningful for you and for us.
Thanks, ma'am. Definitely, the high dose methotrexate level is most of benefited patient is pediatric patient. Before it, we just managing just like a resource poor setting with KFT level only. So if and the timing is depend upon the protocol we use. Different protocol have different timing schedule. According we send, but if we required for lab titration, we can send more frequent sample. And if the TDM form is not filled optimal, better to send back so we get habitual of filling it properly. And again, for ICU, pediatric ICU, anti-epileptic again help a lot to get the optimal level and toxicity. Thank you.